Okay, let's unpack this. Today, we're doing a deep dive into Perthes disease, also known as Legg-Calvé-Perthesdisease.
hmm
You've given us some really detailed revision notes, and our mission here is to pull out the absolute must-know info to help you really get a grip on this childhood hip disorder.
Exactly. We'll be hitting everything from, what it actually is and who it affects, right through to the management side and what the long-term picture might look like.
Think of it as your shortcut, maybe.
Yeah, streamlined guide. We'll sprinkle in a few memory hooks, too, just to help make it all stick.
Great. We're working from a pretty comprehensive overview of Perthes. So let's just dive straight in. What is Perthes disease, basically?
Okay, so at its core, Perthes is a condition affecting kids' hips,
Hmm.
specifically the blood supply to the round top part of the thigh bone.
Femoral head.
The femoral head, exactly. That blood supply gets interrupted. And when that happens, well, the bone cells don't get enough oxygen, not enough nutrients,
Right.
which leads to something called avascular necrosis,
Mhm.
basically bone cell death. Think of it like a temporary power cut to a really crucial spot.
And which kids usually get this? What's the typical age?
We generally see this in children between about 4 and 10 years old.
Okay.
And a key thing you, as a parent or clinician, might notice is the child starting to complain of hip pain,
Hmm.
maybe developing a limp,
Hmm.
or perhaps just not being able to move their hip quite as freely as before.
Now, you mentioned it's self-limiting. That sounds counterintuitive, maybe.
Yeah, it does a bit, doesn't it?
Yeah.
But it means the body does try to heal itself. It will attempt to restore that blood supply and repair the damaged bone.
But there's a catch.
There is, because that whole process, losing blood flow, then regaining it, can unfortunately cause changes in the actual shape of the femoral head.
Oh.
It goes through this cycle. First, the avascular necrosis, the cell death at the top of the femur. Then you get this phase of, kind of abnormal bone growth as the body scrambles to fix things.
Mm.
And finally, the bone remodels itself. It's like the hip's going through a major renovation, but, a problematic one.
Okay, so what actually causes that initial blood supply disruption? That feels like the key trigger.
It absolutely is the key trigger, but
Okay.
the honest answer, the exact cause of Perthes disease is still unknown.
Really? Still?
Yeah, it remains one of the sort of mysteries surrounding this condition.
So we know the what happens next, but not the why it starts.
Pretty much. We understand the sequence. The problem with circulation, the ischemia, lack of blood kicking off the bone cell death, and all the changes that follow.
Hmm.
But what flicks that first switch? We're not sure.
Yeah.
We do have some clues, though, about things that make it more likely.
Like risk factors.
Exactly. Genetics might play a part. And certain risk factors have definitely been identified. Things like being born with a lower birth weight,
Okay.
exposure to cigarette smoke during pregnancy, and maybe even some specific blood clotting disorders. So it's likely not just one thing, probably a combination of factors.
Let's zoom in on those risk factors then. Age seems pretty clear-cut.
Definitely. That 4 to 10-year-old window is the prime time.
And you mentioned boys earlier.
Yes, it's significantly more common in boys. The data usually points to a ratio of around 4 boys to every 1 girl affected.
4 to 1, wow.
Sometimes even reported as high as 5 to 1. Memory tip. Maybe think boys have Perthes. BHP, just remember that higher rate in boys.
Okay, BHP. And genetics, if it runs in the family.
Well, there might be a slightly higher chance if there's a family history, but it's really important to stress it doesn't follow a simple inheritance pattern.
Right.
Having, say, an uncle with Perthes doesn't mean a child is destined to get it.
Understood. And those other factors, low birth weight, smoking.
Yes, those have been pretty consistently linked in studies. Low birth weight and maternal smoking during pregnancy seem to be genuine risk factors. And like I said, those blood clotting conditions are also being looked at.
Okay, let's get a bit deeper into the pathophysiology. What's happening right down at the, tissue level?
Right. It all starts with that blood flow disruption to the femoral head. Just imagine those tiny little vessels feeding the bone. Suddenly they get narrowed or blocked or somehow compromised. That's step 1.
The lifeline gets cut off.
Basically, yeah, temporarily. And that lack of blood leads directly to the avascular necrosis, the death of bone cells.
Okay.
Without their usual supply of oxygen and nutrients, the bone tissue just weakens. And then, under the normal pressures of walking, jumping, just moving, this weakened bone can start to lose its nice round shape. It can even start to collapse a bit.
But the body fights back.
It does. The body initiates a repair response. It tries to reestablish that blood flow that's called revascularization.
Right.
And it starts laying down new bone material. Now, this repair process, the revascularization and remodeling, it's essential for healing. But it's also during this active phase that the shape of the femoral head can get permanently altered.
Ah, that's the critical part.
Exactly. It might end up flattened or fragmented, maybe smaller than it should be.
Now, thinking clinically, if a child comes in with hip pain, maybe a limp, Perthes isn't the only possibility, right? What else is on the differential diagnosis list?
Absolutely crucial point. Several other conditions can look similar initially. Transient synovitis is a really common one.
Transient synovitis.
Yeah, it's basically a temporary inflammation of the lining of the hip joint. Usually clears up pretty quickly on its own.
Memo tip?
Think transient, temporary.
Okay, temporary inflammation. What else?
Septic arthritis is a big one, a really important one not to miss.
That sounds serious.
It is. It's a bacterial infection inside the joint. But it usually presents much more acutely, like high fever, really intense pain. The child often won't want to move their leg at all. Very different picture usually.
Got it. Urgent situation.
Definitely. Then you've got things like juvenile idiopathic arthritis, JIA. That's a chronic inflammatory condition in kids that can affect various joints, including the hip. And, of course, you always have to consider trauma, a fracture around the hip. Though usually, with a fracture, there's a clear history of a fall or injury.
Makes sense.
So yeah, ruling these other things out is key to getting to that Perthes diagnosis.
Let's talk numbers. How common is Perthes, actually? The epidemiology.
Okay. In the UK, the estimate is it affects roughly 1 in every 1,200 children.
1 in 1,200. So not incredibly rare, but not super common either.
Exactly. Something pediatricians and orthopods definitely need to be familiar with.
And that gender split we mentioned is pretty striking.
Yeah, that 4.1, maybe even 5.1 male to female ratio is quite consistent across studies. Definitely more boys.
And the age window, still mostly that 3 to 10 range.
That's the peak, yes. The most common age of onset is firmly within that 3 to 10 year window. If you look a bit broader, say under 15s, the incidence is around 1 in 10,000.
Okay. And can it affect both hips?
It can, yes. Bilateral Perthes affecting both sides happens in about 10 to 15% of cases.
So most kids just have it in one hip.
The majority, yes. It's unilateral.
And any differences between populations?
There's an interesting data suggesting it might be less common in non-Caucasian populations. Why that is? Well, that's not fully understood yet. Needs more research.
Okay. So clinically, what are you actually looking for? What are the key features that would make you suspect Perthes?
Well, the onset is usually pretty gradual. Insidious, we sometimes say.
Not sudden.
Not usually, no. Parents might first notice their child mentioning some mild pain, maybe comes and goes, in the hip or groin area. Interestingly, sometimes that pain can actually be felt more down in the thigh or even just the knee.
Oh, okay. That could be misleading.
It definitely can delay things sometimes. A limp is another really common sign, often one of the first things noticed. You might see the child trying to kind of avoid putting their full weight on that leg.
And their movement.
Often restricted. You'll typically find a reduced range of motion in that hip joint, specifically movements like abduction that's moving the leg out to the side, and internal rotation, turning the leg inwards. Those tend to be limited, and trying to do them can be painful for the child. Memory tip. Think AI out. Abduction and internal rotation are the movements often affected.
AI out. Got it. What about x-rays early on?
In the very early stages, x-rays might be subtle. You might just see a slight widening of the joint space between the ball and socket. Later on, as that avascular necrosis really progresses, the x-rays start showing more obvious changes. The femoral head might look smaller or denser, maybe fragmented, and you can start to see it losing its nice round shape, becoming flattened.
Are there other things to note clinically?
Yeah, it's important to remember this usually develops over weeks, maybe even months. It's not like an acute injury. And also, unlike an infection like septic arthritis, you typically don't see those systemic signs. No fever, no significant redness or swelling around the joint, especially early on.
You mentioned the limp. Does the way they walk have a specific name?
It can do. Because of the pain, they might develop what's called an antalgic gait. It's just a pattern of walking where they try to spend less time bearing weight on the painful side.
Okay.
In later stages, if the hip abductor muscles become weak, you might even see a Trendelenburg gait, which is a more specific type of limp where the pelvis drops on the opposite side when they lift that foot.
And that roll test you mentioned.
Yes, the roll test. You gently roll the child's whole leg inwards and outwards while they're lying relaxed. In Perthes, this movement, particularly rolling it inwards, internally rotating, often causes muscle guarding the muscles around the hip, instinctively tighten up to protect the joint, or it might just elicit pain or spasm.
Right. So putting it all together, how did doctors actually confirm it's Perthes? What investigations are standard?
X-rays are definitely the first step, plain X-rays of the pelvis and hips. And as we said, that specific frog leg lateral view can be particularly useful for seeing the femoral head clearly.
Okay. And if the x-rays are uncertain or you need more detail?
Yeah, if things aren't clear, or maybe to get an earlier diagnosis before X-ray changes are obvious, you might move to more advanced imaging. A technetium bone scan could be used, or, more commonly these days, an MRI scan. MRI is really good at showing the blood supply, or lack thereof, and the state of the bone, often much earlier than X-rays can.
So MRI is pretty sensitive.
Very sensitive for picking up those early vascular changes, yes.
And how do you track it over time?
Serial X-rays are the mainstay for monitoring. Doctors will get X-rays periodically, maybe every few months, to watch how the disease is progressing.
Right.
They're looking at the stages of fragmentation, collapse, and then hopefully the reossification, the healing phase. And importantly, assessing the shape of the femoral head as it heals.
Any other tests sometimes used?
In certain situations, particularly if surgery is being considered, an arthrogram might be done. That's where they inject contrast dye directly into the hip joint, often combined with an MRI, an MR arthrogram. It helps to see how well the femoral head, the ball, fits inside the acetabulum, the socket, especially during movement. It assesses the congruency.
Okay, for surgical planning.
Exactly. And just to reiterate, if there's any real doubt about infection,
That's like arthritis.
yeah, even though the clinical picture is usually different, if there's a strong suspicion, a hip aspiration is needed. That's taking fluid out of the joint with a needle to test it for bacteria. Rule out infection.
Got it. Okay, let's talk management. How is Perthes actually treated, say, here in the UK? What are the goals?
So the main goals are, 1, manage the pain and any other symptoms the child has.
Right.
2, maintain or restore a good range of motion in that hip. And 3, crucially, try and keep the femoral head well contained within the hip socket, the acetabulum.
Contained, what does that mean exactly?
The idea is that the socket acts like a natural mold. If you can keep the softened, healing femoral head nicely seated inside that mold, it's thought to help it maintain a more rounded, functional shape as it rehardens.
Right. And is it always surgery?
Oh, no, definitely not.
Yeah.
Especially for younger children, generally those under 6 years old, when diagnosed non-operative treatment is usually the first line.
And what does that involve? Just waiting?
Not just waiting, but actively managing. It usually involves some activity restriction, maybe avoiding high-impact sports for a while,
Okay.
and sometimes limiting how much weight they put on that leg, perhaps using crutches for a period, until the bone starts to show signs of healing and hardening, reossifying.
Yeah, and physiotherapy.
Very important. Physio plays a key role in maintaining that hip range of motion, preventing stiffness, keeping the muscles around the hip strong.
What about things like braces or casts? Do they work?
That's a bit more debated, actually. The evidence for using orthotics, like braces or special leg casts, routinely in non-operative management.
Well, it's somewhat limited. It really depends on the specific case and the treating surgeon's philosophy.
Okay, and pain relief. Yes, absolutely. Pain needs to be managed. Non-steroidal anti-inflammatories, NSAIDs like ibuprofen, are often used as needed for pain and any inflammation.
And how well does this non-operative approach work for those younger kids?
It can work quite well. Some studies suggest that up to 60% of younger children managed non-operatively can have good long-term outcomes.
60%, that's pretty good. But sometimes surgery is needed.
Yes. Operative treatment might be considered, especially in older children, say over 8, or if the femoral head isn't staying well contained within the socket despite non-operative measures, when it looks like it's starting to deform or come out of the socket.
And what kind of surgery?
There are a few options. Osteotomies are common. That means cutting and reshaping bone. You can do a femoral osteotomy, reshaping the thigh bone to point the head better into the socket, or a pelvic osteotomy, reshaping the socket itself to provide better coverage over the femoral head. Procedures like valgus or shelf osteotomies are also aimed at improving that containment. Sometimes, minimally invasive hip arthroscopy might be used to look inside and maybe tidy things up. And there's a more complex, maybe more controversial procedure called hip arthrodiastasis, which involves using an external frame to gently pull the joint apart for a time, trying to allow healing space.
Wow, okay. A range of options there. So what's the overall outlook? The prognosis for kids with Perthes?
Generally, for most children who get the right management, the prognosis is actually pretty good. Many recover fully and lead normal, active lives.
That's reassuring.
It is. However, the long-term outcome definitely can vary depending on a few key things.
Like what?
Well, the age the disease started is a big one. Younger kids, like under 6, generally tend to do better.
Okay.
How much of the femoral head was actually affected by the avascular necrosis also matters. The more extensive the involvement, the trickier the outcome might be, and of course how well they respond to whatever treatment is chosen.
Are there potential long-term issues down the line, even if things seem okay initially?
Yes, unfortunately, long-term complications can sometimes occur. It's important families are aware of these possibilities.
Such as?
Things like a lasting deformity of the femoral head, maybe some persistent stiffness in the hip joint, an increased risk of developing arthritis in that hip much earlier in life than usual. And sometimes, though usually minor, a difference in leg length between the two sides.
Let's unpack those complications a bit more. The femoral head deformities, what shape's going to take?
Yeah, that's a key concern. It can end up misshapen in various ways. Doctors use terms like coxomagna, where the head is too big,
Okay.
coxoplana, where it's flattened, coxobreva, where the neck part is short. Or you might get something called hinged abduction, where the misshapen head sort of jams in the socket when the leg moves outwards.
Right. And stiffness.
Yes. Even after the disease process itself is over, some people are left with a hip that just doesn't move as freely as the other side. A reduced range of motion can be a lasting issue.
And the arthritis risk sounds like the big one, long term.
It is probably the most significant long-term worry because the joint mechanics are altered by the changed shape of the femoral head. It leads to abnormal wear and tear over the years. This significantly increases the risk of developing painful osteoarthritis, potentially requiring hip replacement surgery, perhaps in their 40s, 50s, or 60s, much earlier than average.
And the leg length difference.
If it happens, it's usually not a huge difference, maybe a centimeter or two, but even a small discrepancy can sometimes affect gait or potentially lead to back pain over time.
Okay. And finally, hip joint incongruity.
That just means the ball and socket don't fit together smoothly anymore. They're not congruent. That imperfect fit, again, contributes to uneven pressure, wear and tear, and ultimately the risk of arthritis.
So it sounds like even if the childhood treatment goes well, long-term follow-up, or at least awareness, is pretty crucial.
Absolutely. It's true that sometimes even a somewhat deformed head can be tolerated without symptoms for many, many years.
Right.
But the studies do suggest that a pretty significant proportion, maybe around half of individuals who've had Perthes, might develop disabling arthritis by the time they reach their 6th decade.
Wow, 50% by their 50s or 60s.
Yeah, it really highlights why getting the management right during childhood, aiming for the best possible shape, is so important, and why ongoing monitoring might be needed.
Okay, so let's try and wrap this up. Key takeaways for Perthes disease.
All right, Perthes. It's a complex childhood hip thing,
Yeah.
caused by the temporary loss of blood supply to the femoral head. Key things to remember are that typical age group, 4 to 10 years. In fact, it's much more common in boys. The usually gradual start, with hip pain and a limp, the whole process of avascular necrosis followed by remodeling.
Yeah.
And that crucial treatment goal, containment, keeping that femoral head in the socket to help it heal round.
And for revision, definitely lock in those features. AVN in a 4-10-year-old, the slow onset limp and pain, the containment goal, and maybe our memory jogs. Boys have Perthes, BHP, and AI out for the restricted movements, abduction, and internal rotation.
Sounds good. And this all raises a question for you, the listener, to think about. Now that you understand the potential long-term complications, how might that influence how you explain Perthes to families? How might it shape the conversation about sticking with treatment plans and the importance of follow-up, even years later?
That's a great point. Food for thought. And listen, for much more in-depth revision material, loads of practice questions to really test yourself on Perthes and all the other MSRA topics, definitely check out passandterry.com.
Yeah, great resource. And for a ton of free learning materials, too, don't forget freemsara.com.
Excellent. Keep diving into these topics, focus your revision, and you will absolutely master this stuff.